and scientist practitioner who has worked with children, youth, and families for over 30 years. He is a clinical professor in the School of Psychology at the University of Ottawa. He is the Executive Director for the Ontario Centre of Excellence for Child and Youth Mental Health. He serves as the inaugural co-chair of the National Infant, Child and Youth Mental Health Consortium and the principal lead for the National School-Based Mental Health and Substance Use Consortium. Dr. Ian Manion is actively involved in research on patient-child interactions, mental health promotion, youth depression, and suicide. He is an advocate for child and youth mental health, sitting on local, provincial, national, and international boards and committees. He is the co-founder of YouthNet, a bilingual community-based mental health promotion program with satellites across Canada as well as in Europe. This program strives to understand the mental health issues facing young men and women and to better address these issues with sensitivity to gender, age, culture, and geography. So I'm going to turn it over to Ian now.
Let's see what it looks like. I call him the surfer dude. He's my boss.
That's okay. Hi, folks. It's a pleasure to be joining you today. I'm just going to ask those who are on the phone to mute your phone because we're getting a little bit of feedback. So the way to communicate is really the chat function, so I encourage you to do that. And I am technologically challenged, so if I make a mistake, I apologize in advance. Pour nos amis francophones, la présentation aujourd'hui aura lieu en anglais. Si vous avez des questions, des commentaires, vous pouvez les poser en français. Je vais les répondre en français. Éventuellement, les diapositives seront disponibles en français aussi, mais juste pas aujourd'hui durant la présentation. Alors, on me demande pour votre patience là-dessus. So today, we're going to be doing a lot of different things. And just to give you a sense of what I'm going to try to cover, give you some facts and figures about youth suicide, the role of evidence in general, and more specifically as it relates to youth suicide prevention. A very recent review of the literature that I have the privilege of being involved with a large team from across Canada, looking at the best evidence in youth suicide prevention. Some of the major research initiatives going on right now, guiding work at a whole community perspective in youth suicide prevention, what's going on in Canada, what we can expect in Canada, and then we'll have time for questions. Okay, so just to this initial slide, for those of you who don't know the Center of Excellence, we have young people engaged in everything that we do. They create these massive murals and to tell us what they think about mental health in general. So they remind us of why we do the work that we're doing. So just to give you a sense about when we talk about youth suicide, and this is a tough topic. Many of you are working in this area on a day-to-day basis. You've had some very difficult situations to deal with, and I really understand that we need to talk about these things with sensitivity. So this gives you a bit of the sense in terms of the numbers and scope of the problem that we're talking about. It is the second leading cause of mortality among 15 to 24-year-olds. If you look at non-accidental death, it is the leading cause. Often it is associated with a mental illness, but not always. Young men die by suicide more often than young women, but young women think about it and actually engage in more suicidal behavior than young men. So it's quite complicated in terms of what's going on from a gender perspective. We know that certain communities, First Nations, Inuit, Métis communities, for example, are more likely to experience loss by suicide, but that's not every community. So we have to be very careful when we overgeneralize the communities. Many First Nations communities actually have lower suicide rates than the national average. So what is it about certain communities that makes them more resilient, makes others more at risk? So, similarly, LGBTQ individuals that would be part of that community, they talk again about a larger prevalence of death by suicide than looking at heterosexual suicide rates. But that is not a simple thing either. It's much more complex than that. We know that individuals that have had an attempt are more likely to attempt again. And we know that a suicide attempt is one of the greatest predictors of future suicide attempts, probably 10 times more likely. And if you look at the general population, about 1 in 5 of those who have ideation will have serious ideation with attempts. Now, You might wonder why I have a picture of two elephants. It's not because of reminding you what the elephant in the room is, but perhaps it's a good reminder that this has touched probably all of us in one way or another. When I do speeches, I often have a session where I have people stand up and sit down when they answer questions. And one of the questions is if they know someone in their personal life that's made suicidal comments, engaged in suicidal behavior, or who's died by suicide. Almost 80% of the room stands up when that question comes up. And I put this picture up to remind you we're not just talking about numbers, we're not just talking about statistics, we're talking about people. This happens to be my daughter, and she also has suffered from depression, has been suicidal, and it makes it quite real when you think about why are we doing this work, and maybe it's touched some of you in a very personal way. So even though we're going to be talking about research and evidence and statistics, let's not forget we're talking about people and lives and circumstances that can be quite challenging. So in our community, we've been collecting information through the YouthNet program for many years now, and this slide gives you a sense of the prevalence that we have seen of those young people that tell us they've had past suicidal thoughts. So you'll see here that it's about 17% of young men, 31% of young women tell us at some time in their life they've had suicidal thoughts. When we ask about them having such thoughts recently, as in the last 3 to 6 months, you see it's about 7% for young men and double that for young women. And if you ask young people if they have purposely done something that could have ended their lives, if they have purposely tried to harm themselves with some intent for suicide, the numbers are very scary, 7% for young men and 16% for young women. When we look at young people that would describe themselves as out of the mainstream, not just your typical students in schools, but those that might be living on the street, that are incarcerated, or living in more challenging contexts, the numbers rise even more. And these are just attempts. Almost 37% of the young women tell us of more marginalized population that they've done something that could have ended their lives, about 15% of young men. If we look at rural versus urban areas, and many of you may be from rural or remote communities, living in a remote area actually increases the risk, even if you're only in a rural area that's close to a suburban area. So the places where we have the least supports sometimes are the places where the risk can be highest. We need to consider that when we're trying to look at the evidence about how to prevent suicide. One size does not fit all. This is a pretty scary slide because out of all the young people that have told us they've been suicidal at one time or another, we asked them how many have told someone before. And here, 45% of the young men tell us that were suicidal, either thoughts or behaviors, tell us they have never told anyone before. About 33% of the young women. Knowing that there are that many young people that are suffering in silence, that aren't necessarily seeking services, that's something that we have to pay attention to in terms of our prevention. The good news is, and in this particular case, if you ask in the right way, they will tell you. And in this particular project, this is the YouthNet project, in a safe environment where the right supports are there, young people will actually tell us when they're having these thoughts and they're having these feelings. That's an opportunity for prevention. So as a clinician, I've come to learn that there is no little piece of paper that you can put on a young person's nose that's going to turn blue to tell you that they're going to be suicidal. Predicting suicide is hard, and these two quotes, I think, put it quite clearly. Although risk factor evaluation is a necessary component of suicide assessment, no factors have been discovered that predict suicide completion at an individual level. It's still based on intuition, clinical experience, and looking at a number of potential risk factors. Another quote is even more powerful. It's widely recognized from a scientific standpoint that the accurate prediction of any individual's behavior, especially the prediction of suicide, is statistically impossible.
We have one clarification
Yes?
question, Ian. On the previous slide, you have mainstream versus non-mainstream, and somebody would just like you to clarify that.
Okay. So when I talk about mainstream in that particular piece of work, and this again is from the YouthNet work over 20 years, mainstream would be young people that were accessed through regular school programs in regular schools. Non-mainstream would be students in alternate programs, alternate schools, street youth, incarcerated youth, youth in care, youth on reserve, youth that would identify as being outside of your typical mainstream classroom. Of course, there are people in mainstream classrooms that would also have less traditional backgrounds, but this, the non-mainstream group here is identified by where they were accessed. So what we have found typically is those young people that congregate around service things like youth in care, youth incarcerated youth, or living in challenging circumstances, which you have named non-mainstream, have higher risk factors for just about everything. Okay, so risk factors, we have to be careful when talking about risk factors. Risk does not equal causality. Just because you happen to have a risk factor, it does not mean that it causes that problem. So for example, if you are First Nations, First Nations does not, being a person who's First Nation does not cause being suicidal. If you are living in a rural area, that does not cause being suicidal. There's an association, there's a correlation, there's a greater possibility perhaps. And think about the more and more the risk factors that you accumulate, perhaps the possibility increases over time, but it's not a one-to-one direct kind of a thing. So we have to be careful in our language. Sometimes when we identify someone as being from a risk group, we forget things like resilience. We forget things like personal attributes that can overcome whatever that risk factor is. In looking at some of the predictors based on research, we know that the best predictor of suicidal behavior is past suicidal behavior. So some of the research actually looks at the at-risk group of those who have already presented once or more with suicidal behavior and what can be done specifically with them. Those who suffer from a psychiatric diagnosis, and not just depression, it could be other diagnoses as well. We know that when you look at the research about people who have died by suicide and do something called a psychological autopsy, where you go back and look at all the information and try to figure out what may have happened, about 90% of the cases there was diagnosed or undiagnosed mental illness. So that provides us with an opportunity for prevention as well, identification and effective treatment management of underlying mental health concerns. And the third is access to lethal means. So again, this is a risk factor. Having a gun in your household, if you happen to be working on a farm, might increase the risk but doesn't cause a suicide. Many efforts have looked at how can you reduce access to means as a way of preventing suicide. So what can we do about all of this? I mean, this is a huge problem. In my own experience, I get quite upset whenever I hear of a young person dying by suicide. One death by suicide is too much. How can we prevent even one to make a difference? Because it makes, when someone dies by suicide, it's like a ripple throughout a community. It just affects everybody and for a very long time. So what can we do to actually make a difference? So if we're talking about evidence, what does the evidence tell us? We have a poll here, if I think correctly, if I'm right about this. And what we're going to ask you to do, are you currently, would you say that you're using evidence-based practice in your day-to-day work? So right now, in your day-to-day work, whether you're in a school board, in a children's mental health center, in a community health center, if you're a provider of services of any time, do you use evidence in the work that you do? And I'm looking at the poll, and the numbers are quite high. You seem like you all embrace evidence, which is great. But now I'm going to ask you to think about this a little bit differently. You don't have to do this in the poll. You can keep answering the poll if you're doing this. But think about the places where evidence exists. Evidence does not just exist in terms of an intervention. You can have evidence in how you assess risk and how you track risk. You can have evidence in the service that you're providing, but also how you provide the service, not just what the service is, but how you provide it. There's evidence to guide training. What's the best way of training people to be aware of the risk factors to look at? There's actually evidence to guide policy, and we've done a lot of work in developing, helping develop policy based on the best available evidence. And there's even evidence that talks about how you learn about evidence. So how do you talk about these things? And I hate to say this, and I'm going to say it apologetically, sitting in front of your computer and having me talk to you on the computer is not the best way to learn stuff. The best way is actually having relationships with people, having ongoing conversations. So if you happen to be watching this with colleagues, I would encourage you to have a conversation amongst yourselves, share information online with us, ask us questions. The interchange is how you actually gain knowledge and use knowledge in the most effective way. And my screen is now frozen. Oh, we have another poll. Okay. So in this poll, for every question, I want you to think about when you make a decision, whether it's about a young person you're trying to serve or not, I want you to tell me yes or no, whether you make your decision based on what your intuition says, so what your gut says. Can we advance this slide?
I can do that.
Oh, let's try it from down here. Okay. Your intuition or your gut, what you've heard from other professionals or informal exchanges with colleagues, what you learned from previous examples or cases or experiences, the outcomes of data that you may have collected in your care, what your agency organization usually offers, what you've heard from clients, what you're most familiar or comfortable with, what you know about from what you've read in research or theory, or what you learned in your own training, even if it was like 30 years ago. So yes or no, what do you use to guide your decisions? And I can't see the results of the polls, but the answers are still coming. We'll just give it a sec. Intuition is 50%. So it's interesting because when we ask you folks to use evidence to guide what you're doing, you still trust your gut more than anything else. So now we're going to move to the next slide, I hope. So now let's say that we're not talking about someone you're serving. Let's say that you are suffering from a serious medical condition, and you know that it's serious, and you have to get help from a health provider. What would you want your doctor to use to make their decision? And again, go down the list. To what extent you want them to use evidence versus their gut feelings versus what they learned 30 years ago. How would you want them to change their behavior to better serve you? And again, fill out the questionnaire. Let's take a few seconds for that. And any responses on the polls? What is it?
Looking at 83% his or her previous experience.
So it's still quite high in spirit, but not just gut?
No. Gut's pretty low now, 20%.
Right. So it's interesting. When it's about you or your family member, you really want to base it on something that's more substantial. You want it to be on evidence, whether it's your own practice or practice of somebody else, and not just trusting your gut. So you're a lot like me. Oh, there we go. So when we talk about evidence-based practice, we're not talking about what we think we know or what our gut tells us. It's what we really know that works. And when we talk about what we know it's based on different types of evidence. So this is a definition of evidence, and I'll just read this quickly to you. Evidence is information that comes closest to the facts of a matter. The form it takes depends on context. The findings of high-quality, methodologically appropriate research are the most accurate evidence. So evidence does come from research to a certain extent, but not only from research. Because research is often incomplete and sometimes contradictory or unavailable, other kinds of information are necessary, supplement to or stand-ins for research. The evidence base for a decision is the multiple forms of evidence combined to balance rigor with experience while privileging the former over the latter. So where there's research, we want to use it. Where there's not research, we want to get the best available other information possible. So in the United Kingdom, they talk about research not being enough. It has to be added by clinical experience. It's about looking at the context. It's also understanding the preferences of young people, families, communities. And at the center, we actually moved away from the term evidence-based practice to recognize that there's a lot of other knowledge out there. And think about the traditional knowledge that exists in many communities, especially First Nations communities, where we can learn a great deal based on that practice-based evidence or historical evidence. So the sweet spot for evidence-informed practice is that intersection of what we know from research, what we know from practice, but also what we know from those we're trying to serve. There are preferences. There are things that might be suggested by research that people would never want to use. And this is what guides most of the work that we do at the center. So evidence-informed practice combines the best available research with the experience and judgment of practitioners, children, youth, and families to deliver measurable benefits. And experience and judgment of not just practitioners. There are elders, there are natural healers, there are many people that have experience that we should be listening to. Evidence-based practice is not a do-all and end-all. There are many things that we know that limit our ability to use evidence. First of all, sometimes the evidence just doesn't exist. We haven't done the research yet, or we haven't done it in a certain context. Sometimes research is too pure. We have a group of individuals that we've researched that you don't really find in the real world. I'll give you an example. There was a study done once looking at depression in adolescents, and the adolescents could only be depressed. They couldn't have any other diagnosis. They couldn't be on medication, and they had to come from intact families. I don't know many young people that would fit those criteria in the real world. So when you take sometimes things done in very pure, homogeneous, ideal conditions and translate that to the real world, sometimes you can miss out. Or the intervention that works really well, provided that you have a child psychiatrist providing every session of treatment to that individual. There are many communities that will never see a child psychiatrist, so it may not be feasible. Many promising practices have never had the opportunity to be evaluated. So there are many hidden gems out there. You folks are probably doing things right now that are at least seem to be working for you. But how do we capture that? How do we gather the information so that others can learn from your experience? And unless we evaluate, we miss out on that. As I mentioned, some interventions aren't feasible because of the resources required or the populations that might be present. And the other thing is that a lot of people want to do good, and when there are bad things happening, they want to innovate. They want to try something. They want to bold to go where no one has gone before. Where if you're the first to try it, it hasn't been evaluated yet. So innovation doesn't equal evidence-based practice. It can eventually if you evaluate, but at the front end it doesn't. So how do you make sure you're not doing any harm? Very important when talking about the evidence base is a lot of research is not culturally sensitive. It looks at general groups. It doesn't necessarily look at all the conditions or factors that are listed on this slide. How can we take evidence from one context and expect it to actually work in another context? And who knows that context best? So increasingly we're trying to do research on different subgroups, but the permutations and combinations are endless. I mean, you can have so many different characteristics of individuals. How do you make sure that you're looking at each individual and not just the average of an individual that may not exist in the real world? There are barriers sometimes to actually using evidence. Your organization may be such that you don't trust research or you don't have access to the research. Maybe you know that there's a problem, but changing is hard. It's very hard for you to make change happen for a variety of reasons in your organization, in your community. Sometimes being able to use the evidence, taking the time to find it, understand it, and apply it seems to take time away from the really hard work you do on a day-to-day basis. How do you press the pause button to actually incorporate research in your practice? And maybe you lack some of the resources or the expertise in terms of accessing and understanding some of the literature and some of the evidence. And even when the literature is clear and the evidence is clear, how do you get access to the training and the ongoing support to use that evidence-based practice? Sometimes there's great costs associated with that. We're curious about the extra barriers that you experience in your communities, in your agencies. And I think we have a poll where folks can just add any additional barriers that come to the top of their head or they face on an ongoing basis. Take a minute just to do that. Are we getting any?
Yeah, we are.
So what are some of the things that folks are saying?
Even the highest is often viewed as an add-on.
So often viewed as an add-on? Yeah, no time to do.
Access to training.
Yeah, access to training. Any ones that are new ones like other that they've written in? No. Okay. So it sounds like it's right across the board. These barriers are resonating with you. Oh, again, I can't. Oh, we go. So when you think about evidence, think about two things you have to do. First, you have to be able to evaluate the value or the strength of the research. Research isn't just asking people how they like things after they did something, or whether they think it worked for them. So there's a whole bunch of things to look at in terms of the scientific rigor. What was the level of the research? Was it based on sound methodology? Did they track the right kinds of outcomes over time? So that's one side that you have to consider, and sometimes you need to have some guidance in doing that. One of the things that the Center of Excellence does is guide people to understand that scientific rigor. But the other side of this is what's the reality for you in terms of feasibility. So for example, if you're in a school board, does the program fit with your board's priorities or the resources or the directions or the policies you have in place? Does the program actually meet the needs that you've identified? Is it complementary to what you're already doing, or does it make you have to drop things and change too much? Is it available to you, readily available to you? Think about a good program that's only been done with Anglophones with no equivalent for Francophones, as an example. Is it affordable? Sometimes, I've done lots of work in lots of settings around suicide prevention, but also postvention. And I know, sadly, when there's a death in the community or a student in a school dies by suicide, schools are often inundated by purveyors, those who have products, who are trying to tell you that if you just buy this product from them, you just use their program, they'll solve your problems forever. Well, those are very expensive to do, and it's hard to tell one good program from the other. And once you start using a program, how does it stick? How do you make sure that you keep training people and you maintain some fidelity to the program that you're doing? So at the end of the day, you want to know whether the evidence suggests that what you want to do can be implemented. Is it available? Is it affordable? And is it feasible in your context? So now we're going to get more specifically into evidence-informed practice as it relates to suicide prevention. And the bad news is, I am not going to tell you if you use program A, your problem solved. It's not a prescription. It's not if you just do this, everything's going to be okay. Consider it as guidance. Consider it as guidance, not a prescription. The other thing is that it's not the evidence that makes a decision. You're using evidence to allow you to make an informed decision. And that decision is guided by all kinds of things: your context, your history, your resources, your capacity, your preferences, and your evidence. The evidence that you have and the evidence that exists from others. And the last piece to remind yourselves is no matter what we do, we don't want to do harm. It's very easy sometimes to want to do good, and inadvertently we can actually do harm. And too often the research does not look at harm. So how do you balance off the benefits of doing a program or taking on an activity versus the potential harms of doing that to reach a decision that makes sense in your context? And that's what we're going to be talking about next. There's also a research challenge. Now, I'm a researcher who does research in suicide prevention. I've been doing it for a number of years. It is very hard to do. First of all, again, one suicide is too many, but suicide itself is actually a fairly low-frequency behavior. So to actually measure a change in a low-frequency behavior is hard to do. So it's hard to have death as an outcome because death does not happen as often, gladly, as often. In some communities it happens a lot more often, unfortunately. In terms of if you're not looking at death as an outcome, people disagree about what you should look at instead. Is it suicidal thoughts? Is it presentations to emergency rooms? Is it suicidal behavior? And don't forget that slide I showed you before. 45% of young men that were suicidal never told anybody. So if you're looking at how they talk to someone else about it, don't assume you're getting the full picture. If you're only looking at those that present to get support, don't assume you're getting the whole picture. So people disagree on that proxy. Another problem is most people don't evaluate the work that they do. And we'll get to that in a minute. Some of the best intentions and lots of energy and sometimes massive funds have been put into programs that have never been evaluated. So we don't know always what works. And even if we know what works in one community, it's very hard to scale that up across a province, across a country, because context is different. So there's real challenge in making good things happen across communities. So do we have a poll here? No. Okay. So the next thing I'm going to talk to you about is a large piece of research that was completed recently. There was a very significant team of individuals around the country. It was led by Dr. Kathy Bennett from the Offord Center and Dr. Katerina Manassis from Sick Kids in Toronto, and looking at the best available evidence around youth suicide prevention. And the research that was reviewed was anywhere in the world. It was published this year in June. And if you may recognize some of the names on this list, these are the leaders in youth suicide prevention in Canada. Some of them specialize in school-based, some specialize in emergency rooms, some have experience with First Nations, some have experience with New Canadians. It's quite, this is like the dream team of researchers who all agreed to try to get this right together. Two questions that we were looking at. What is known about effective school-based interventions to prevent youth suicide? What is known about effective interventions for youth at risk? That would mean those who have already had a suicide attempt at some point in their life. These are the kinds of interventions that we looked at. We were not looking, for the most part, at individual packages or programs, but rather categories of programs. And you see here, we looked at education and awareness for the general public, screening tools, treatment of psychiatric disorder, treatment of serious suicide-related behaviors, restricting lethal means, media reporting, postvention, and here are some examples on the right of kinds of things that people did. And what I'm going to do is I'm going to show you by category, if I can do this, just to give you, explain to you a little bit how this works. So this are looking at effects of school-based prevention efforts. And on the left, I can just get my pointer. So here you see these are the kinds of things we looked at. And here you see the number of reviews for each one of these. So suicide awareness curricula, there were 6 good studies that looked at that. And if you get a little bit further, we looked at the outcomes. How many of these looked at death as an outcome, attempts, ideation, or knowledge and attitudes? So the first thing that you see, if you look at school-based prevention, out of all these things, none of the studies showed death as an outcome to have been affected, either because they didn't measure it or there was no effect. Some had outcomes like suicide awareness curriculum on attempts, skills training had outcomes on attempts, screening had outcomes on attempts, and then information skills training also had on ideation. Almost all of them had benefits on knowledge and attitudes. So if you're just looking at knowledge and attitudes, you can see that you'll probably get some change. Whether that's going to prevent deaths or not, we don't have really good evidence to support that. Okay, I'm just going to move on to the next one. This is looking at who have attempted suicide. These are the people that are at risk. Whoops, sorry. At risk, who have had at least one suicide attempt, and these on the left here are the kinds of interventions that were looked at. These are the number of reviews that are available for each one. And you see that there are studies that show that if you make changes in the emergency department, there are programs that have been developed that actually will demonstrate a decrease in death by suicide if you apply them in context with fidelity. Similarly, you see that if you were, and this is looking specifically at people that have been diagnosed with a psychiatric illness that receive appropriate treatment. This is a pharmacological treatment where there was a reported decrease in suicide deaths for those who were treated effectively for their mental illness. In terms of attempts, many of these have benefits for attempts. And again, you'll see most of these are interventions, one type or another, for underlying mental illness. Interestingly, if you're looking directly, I should put it over here, for suicide-related behaviors, if you look at medication for the suicide itself, there was no study showing benefit for death attempts or ideation. So these are those who already sought care. They've already gone, they're looking for care, they've gotten care, and these are the evidence that suggests what can be beneficial. But what about those that don't seek care? And this is, again, think about that slide I showed you before. 45% of young men won't seek care, and young men die by suicide more often than young women. There's very little that we know about this. There's very little to guide us in this regard. We know that things like universal screening, gatekeeper training are done all the time. We know that gatekeeper training, like suicide assist, does increase knowledge and awareness. We don't have good evidence to talk about its effect on death as an outcome or attempts or ideation as an outcome. There is strong evidence to suggest if you can limit the means, then there is a decrease in the suicide rate in the community or a jurisdiction where the means have been decreased. This could be restricting access to firearms, less relevant in Canada perhaps. It could be fences around places where people might jump off bridges or things like that. It's to decrease the impulsive activity of young people. And an interesting note here is when there is a change in the drinking age, there is a drop in suicide because there is a drop in the drinking, which is believe it or not, something that increases impulsivity. So there are some policy kinds of things universally that can attack and really target those individuals that would never tell anyone, but still the evidence is very weak. So this group of professionals that got together to do this research, just to be honest with you, we had to review all this literature. We didn't agree. Many of us had difficulties in terms of the level of evidence or the lack of evidence that existed for one intervention or the other. But these are the recommendations that we did agree on at the end of the day. And so if you look at school-based prevention, in terms of universal prevention, there are advantages to suicide awareness curriculum plus screening. One example of a program was Signs of Suicide that seemed to have some benefits. Skill training, one example was the good behavior game that seemed to have good evidence. Again, not necessarily for death by suicide. Gatekeeper training, if it was paired with things like peer support, and here the sources of strength was mentioned as a program. Targeted prevention intervention, not universal, but where everybody in the at-risk group gets it. So suicide awareness curriculum incorporated into schools. Skills training also seem to have some benefits. For those who attempt but also seek care, those that go to the emergency rooms, lots of evidence to suggest that we can make modifications in emergency rooms that will decrease the person who's made an attempt from having another attempt or dying by suicide. And we should be very aggressive in partnering with our emergency rooms to make sure that those pathways are clear. We know that many people that die by suicide have seen a family doctor or a primary caregiver in the days, weeks, or months before that suicide attempt. And yet the training we have given to those in those roles is very limited. So there's evidence to suggest, at least in one randomized controlled trial, if we engage primary care and give them the tools, they are better able to identify young people at risk and find the right level of support to decrease the risk and decrease the prevalence of death by suicide. And if we identify particularly young people with depression and treat that depression in a meaningful and effective way, we also see decreases in the rates of suicide. For those who don't seek care, gatekeeper training might be promising. Not enough evidence yet. Need to ask more. When there has been a death by suicide, there's some evidence if you do postvention in the right way, if you are having the right conversations, if it allows for a community to develop programs to create pathways for people to get help, that can make a difference. In terms of sex and gender differences, not enough people do good research on this. We have to do much better research. And we're talking about First Nations, Inuit, and Métis communities. It's not up to our group of researchers to do research on communities. It's actually up to those communities to own that research, to clarify the questions, to invite others to join them if they would like, to figure out what makes sense in terms of their unique culture and their context. And the conclusions that are drawn may be very different than the conclusions that are drawn in other communities. Excuse me, there are also strengths in those communities that should be replicated in non-First Nations, Inuit, and Métis communities? How can we learn from traditional experience and learnings that our partners, our colleagues in First Nations communities have been aware of for generations? So I want to talk a little bit now about not just a program, but an overarching approach. One thing that we do at the center is that we've been really promoting a whole community approach to youth suicide prevention. Lots of advantages to that. When everybody gets it, when the conversation is community-wide, you can actually have less stigma. You can actually access those that would never indicate that they have problems. You're actually targeting the problems in the context where they really occur, and you create clearer pathways to care. It's still hard to evaluate whole community approaches to things. Stigma, even though if it's reduced, tends to be a continued barrier. So what are some of the key elements? And you probably know this already. It's recognizing that in every community there's already some capacity. There are already some strengths. And how do you mobilize those strengths? Youth need to participate, not just as recipients of programming, but as co-creators of programming, co-deliverers of programming. Young people speak to young people more than anybody else. So to not engage them in the solution is not tapping into that natural occurring resource. Suicide prevention should not be a standalone. It should be embedded in a whole mental health approach within the community, a wellness promotion. What we have learned from First Nations communities in particular is it's sometimes more about life promotion than about suicide prevention. So how do we make sure we do that? We have to recognize that not all young people are the same. Not one size fits all. So the evidence might suggest that a program might work for one subgroup, but it may not work for another. Our research looking at urban versus rural youth suggests that the pathways to suicide are very different, and the solutions therefore have to be very different. Let's not just take one program developed in a city and think it's going to work everywhere. When you start doing this work in a community, you have to have champions, you have to have leaders, you have to have buy-in. And does it exist? Otherwise, things won't stick. You have to have a commitment, long-term commitment to looking at these things. No matter what you do, you have to evaluate. If you don't evaluate, you're not going to know you're making a difference. So I'm curious, in your community, to what extent are you engaging young people? In this poll, I'm asking you, is it your primary focus? Is it how you're organizing all of your suicide prevention efforts? Is it only a component of your work? And you see the other answers there as well. Take a moment to write down what you think would be where you would be at in terms of the meaningful engagement of young people in your suicide prevention efforts. So what are we getting so far, folks? Primary? So most of you are saying it's a very big part of what you're doing, if not the main focus of what you're doing. That's great. And if it's the main focus, is it because you have a youth on a committee, or is it because the young people are front and center, many conversations, co-creating with them, modifying what you do based on feedback from multiple youth? Think about how you're actively engaging young people. The center has many tools around how you can do that around suicide prevention on our Together to Live website, but also on our main website we have tools and supports around helping communities and agencies create a culture where youth engagement is just what you do, how you live. It's not an item on a checklist. You say, yes, we had a young person there. It's much more than that. You can just change the slide. Frozen. So there has been some work that's been done looking at a whole community approach. There's a paper by Health Canada looking at community capacity building and mobilization in youth mental health promotion. The author was Peggy Austin. This was done in the community of West Carleton many years ago when they had several suicides of students from the same high school. And they realized they had to have a whole community approach to things. So I would suggest you take a look at that. We have links to that on our website. If you could just change the slide. Why am I not moving? Okay. We've done some research that have quite directly shown that when young people are engaged in meaningful ways, not even just in suicide prevention, but engaged in their community, engaged in their schools, engaged in meaningful activities, their risk for suicide goes down. Their symptoms of depression go down. Their risk-taking behavior goes down. And all the indicators of wellness go up. So there are good byproducts to engaging young people in a general way. And I would suggest you take a look at our Dare to Dream program, which is a program for young people, by young people, engaging young people in meaningful ways to have conversations about wellness, about stigma reduction. I'm putting these up here. These are not suicide prevention programs. These are wellness promotion programs. And there is some evidence to suggest if you are able to increase individuals' capacity, community's capacity, families' capacity, you can actually decrease a lot of risk because they're doing so well. And look at some of the items here. You'll see that engagement, that meaningful engagement of young people there. You see the role of schools, which is so significant in promoting many of these skills. Sometimes the best way to solve a problem is to promote wellness instead. Prevent the problem from ever happening. So now I'm going to talk to you about probably the most well-known whole community approach to suicide prevention, which is the most researched anywhere in the world. I'm going to talk to you about a couple ones. There has been research in Germany from originally the Nuremberg Alliance Against Depression. They had a study, a whole community approach. Now they were not looking at youth. They were looking at 18-year-olds and higher. It was a 4-year action plan, many phases to this. And I'll tell you about the phases in a second. But they had all these efforts in one community, and they compared them to another community where none of the efforts existed. And they saw a 24% decrease in suicidal acts. That included attempts and deaths by suicide. Suicide alone, because it's a low-frequency event, they had a decrease, but again, it wasn't enough to show statistical significance. But they would have had to have a 30% decrease in death by suicide to show an effect, and as you see, the numbers didn't quite reach there. Interestingly, even though it was with adults, including young adults, the most pronounced positive effects, the best effects, were those 18 to 29, suggesting that perhaps this is a way to go for youth suicide prevention. And in their 4 levels of their intervention, they saw that their levels interacted. I'll talk about that a little bit more. So what was included here? Primary care, involving primary care, general public, increasing awareness about the symptoms of depression, identification of depression, and treatment of depression, identifying high-risk groups like those who had a previous suicide attempt and having them access the appropriate level of care for the underlying problems, and engaging the community, the stakeholders, the facilitators, the increasing awareness, some gatekeeper training, making sure people knew what was going on. And the goal was essentially to uncover those that might be suffering, provide them with care, and preventing suicidal behavior. They saw some interesting things happen. As the public became more aware of things, people started asking for help more. They presented themselves. They didn't suffer in silence. They went and sought treatment for things like depression with good outcomes. Physicians were more motivated to get training to know what to do because they realized they were seeing these people early in their course, early at the risk status, and could make a difference. And because the conversation was happening generally in the population, providers were better able to ask the question and get the answer. And the stigma was reduced, so it led to a greater access to appropriate service. So again, this is just to give you a sense of some of the data. And I'm going to just get my pointer. You can see that that here in 2000, what the rate was of suicidal behaviors went down by 19% in 1 year, 24% by 2, 32% by 3 years. In the comparison group, you saw there was virtually no change or an increase, but some normal variability over the years. Very significant difference in terms of the impact of the combined program at a community level. Now this program is going across Europe. It's called the Optimizing Suicide Prevention Initiative, and they've added an extra level to this, and what they've added is the restricting access to lethal means. It's still for a whole population approach, and they are looking at a variety of different outcomes. So they're looking at rates of suicidal acts, they're looking at rates of suicidal acts as their primary outcome, but they're also looking at about how things are working in different environments. Why does one community respond better than the other community? What's the context that's making a difference? They're looking at things in attitudes and knowledge. They're looking at presentation, prescription rates for treatment of things like depression, media coverage. Yes?
Clarification
Yes.
question. What do we define as the age of youth?
So what is the age of youth? It's a very good question. It varies tremendously among people. I've heard 12 to 24 being one age that's used primarily. World Health Organization goes up to age 30. In this particular study, they weren't targeting youth specifically, so their study started at age 18. So you would have that 18 to 25-year-old range would be included in the study, and that's where some of the greatest impact was. At the center, our work is primarily focusing on 0 to 18-year-olds, but we recognize the importance of transitional age youth up to the age of 25. Yes, another clarification question?
So this is based on what you were talking about just recently, and somebody's clarifying the support that you mentioned. Was this support provided to those who were closest to those that attempted suicide?
So there were two kinds of supports. So first of all, they supported individuals in the community at large, which would include people that would be close to those at risk. And they also had that at-risk group, but the supports for the at-risk group were most specifically for the individuals who were in the risk situation. So I don't know if they extended that for the at-risk group to family members. It'd be a good question. I will look it up and find out. I didn't see that in the literature. I thought it was more the direct service to the individual that was at risk. Okay. So now across Europe, you have 100 communities that are doing this. The out of the phase, like I mentioned, they're realizing that just saying you're going to do it isn't enough. Just getting on board isn't enough. Lots of variation across communities. Success factors in terms of the level of engagement. And we have to pay attention to that. What's the context in your particular community? What's going to make people not just say they're going to do it, but actually do it and keep doing it in all of the levels of the intervention. There's another piece of significant work which is similar that's been happening in the United States. This is the Garrett Lee Smith Memorial Suicide Prevention Program. And this is specifically for youth, and it's multiple communities. They fund suicide prevention around the areas that are listed here: mental health awareness, screening, gatekeeper training, community partnerships, linkages to services, crisis hotlines, survivors support programs, so those that have had an attempt that might be at greater risk. And what they found, they've had interventions in over 400 different counties in the United States, where they had controls, counties that didn't receive any supports versus those that received supports. These interventions were between 2006 and 2009. They had decreases in self-reported suicide attempts among 16 to 24-year-olds in a national survey. So they were able to pair an existing survey in those communities and see how it changed over time when you added these elements. And they adjusted things for community size, racial, ethnic composition, unemployment, poverty, all those kinds of things. So in terms of numbers, 57,000 youth were in the communities that received interventions. 84,000 youth were in the communities that did not receive the intervention. If you look at all the numbers at the end of the day, there were 5 fewer suicide attempts for every 1,000 youth in one of those communities. So that's significant. Imagine if you prevent one death in one community. In my mind, that makes all the difference in the world, because the cost of one death is significant, not just to the family, not just to the friends, to the entire community. A little bit of conversation about Contagion, because some of you folks were asking about Contagion. And we talk about Contagion, that's the possibility that another suicide occurs after a suicide in a community or a school has occurred that can be linked to each other. Sometimes, just statistically, you have groups of suicide that occurs with no linkages. When there's a link, that's when you have contagion. That link can be geographic, because you live in the same community. You might be aware of things. It might be it's in your social circle, or it might be psychological proximity. You've heard about it and you identify. So, for example, when Kurt Cobain died by suicide, there was a psychological proximity. Certain people felt very close to that performer, identified with that performer and his music, and were affected by that, and their risk for suicide went up, and there were some deaths by suicide that accompanied that. There's a very good paper that was published a couple of years ago by Swanson and Coleman. Ian Coleman is someone that works very closely with our center. He's part of our expert panel for the work that we do. And they looked at some longitudinal data to show what happens in a school after someone has died by suicide. What they found was exposure to suicide predicts suicide ideation and attempts throughout a school, whether the student knew the other student or not, whether they had a relationship with them or not. So just because there was a loss in that community, there's an impact in terms of thoughts and even attempts. What does that mean? Well, it means in our prevention efforts, we should not assume that only those that are closest to the individual, family members, team members, and friends are at risk. We need to have something that's more universal to that promotes wellness and creates avenues to access support well beyond the typical circles that we imagine. Imagine what happens in your community. How many people are affected indirectly, not just directly. And do your post-prevention opportunities create an opportunity for learning and mental health promotion and wellness promotion? Is it a teachable moment? Is that when you're going to have the most effective chance to identify those that need a little bit of extra help? So a lot of folks from school boards are asking about school board prevention. We've worked closely with School Mental Health Assist, led by Kathy Short. There is a youth suicide prevention guide that's been developed. We've been one of the consultants helping on that. Lots of material in there about using evidence. Suggest you take a look at that. There's also a school mental health decision support tool. How do you assess what program makes sense for you? You try to weed through all of the evidence. And it guides you in talking about some of the things you need to look at when looking at deciding on evidence. We have links to these tools on our website at the Center, along with many other tools about how to mobilize a community, how to engage young people, what are some of the tools around assessment, identification, how do you evaluate a suicide prevention program. Don't have time to go through every single link, but I would really implore you to go to the School Mental Health Assist website, but also go to our website and take a close look at some of those tools. In Canada right now, lots of things are driving the work that we're doing. Bill C-300 has really pushed the government to develop a national suicide prevention strategy, particularly focusing on young people. We are one of the few industrialized nations that does not have a national strategy, and I know that right now the Public Health Agency of Canada has developed a framework. I've had the privilege of being involved in that. It's going to be released very soon. We know that the new government, the Trudeau government, has made comments about wanting to support work in this area. The CIHR Evidence on Tap paper is the one that I presented to you. The Mental Health Commission of Canada has been tasked in their new mandate to have a piece of work that's going to be around suicide prevention, and we're in consultation with them so they can learn from what we've learned already. Partners for Mental Health, which is a foundation that was just looking at mental health in Canada, has also brought people together. I had the privilege of leading that group in developing a protocol, a proposal to the federal government around a whole community approach to youth suicide prevention. That's currently being reviewed and has been shared with the Mental Health Commission of Canada. It's also been included when we're looking at ways of creating integrated service hubs in communities in different locations in Canada, where if you provide the right kind of service that's accessible, we should be tracking suicide as a possible outcome that it has decreases the function of that better access to care. So in general in Canada, we're looking at complex whole community approaches, not one size fits all, not one magic bullet. We're blending universal and targeted programming. We're trying to build on existing capacity and strengths and history, including traditional learnings. We understand that schools are critical, primary care is critical, but you can't do this without young people and families. Youth engagement and family engagement has to be at the core of all of this. We should be using technology to reach especially young people more, and they're helping us understand how best to use technology. We think there are different ways that we can have access to our services, not just going someplace, but wrapping our services around young people. We're looking to partners in Australia, in Ireland, who have developed programs called Headspace and Jigsaw to increase access. We know that we can't just do it and expect things to work. We have to think about the long-term commitment to changing how we do things and looking at things like implementation science to make our practices stick, and we have to evaluate everything. So we can't afford to do nothing. We can't afford to do nothing. Even in the absence of good evidence, we have to do our best. If you're not using evidence, or if there isn't evidence that applies to your circumstance, and you are doing something, you have to evaluate it. You have to evaluate to make sure you're not doing any harm. You have to evaluate it because if it's doing a lot of good, you need to be able to show others what works so you're not reinventing the wheel. We don't have the time, the energy, the resources to chase our tails and keep reinventing the wheel. The Center is committing to helping people develop their capacity, build their capacity evaluation, including evaluation of suicide prevention programs. We have many tools on our website to help with helping you evaluate those programs. And evaluation is not just consumer satisfaction. So why do you want to evaluate? What's changing? What's improving? Are you doing any harm? How much is it costing you to get the benefits you think you're getting? It's always necessary, but it's critical when you're trying something new, especially when there's an evidence gap. You have to evaluate. Now, this is a very complex slide, and I apologize for it in advance. But it goes through the entire thing from recognizing that you have a problem that you have to solve, like youth suicide, to looking at the evidence, and when you have good evidence, how do you actually apply it, and at what point you have to evaluate. And as you evaluate, you're evaluating to improve things, to make it better. Sometimes you're evaluating to gain evidence, to gain support, continued support from a financial perspective. Sometimes you're evaluating to make sure what's working can work for many more people that aren't accessing the process, the product, the service that you've developed. If you're having trouble accessing evidence, you should be contacting partners, including the Center of Excellence, because sometimes it's hard to navigate through all of the evidence. And we view our role as being one way to make it easier for you to get the right kind of information at the right time to change your behavior to have good outcomes. There's a gap between what we know and what we do. Even when we have the evidence, we don't always use it well. We use pieces of it, we use it for a little bit of time, then we give up, or we use it with the champions in place, and when they move on, we haven't put the training in place to train the next group of champions. So we have to really get through that gap between the world of evidence and the world of practice. So it does take that effective evidence. So we need to know what the evidence says, what works. We need to know how we can implement it. What's the world of implementation tell us about what's most likely to work, whether it's the right kind of leadership, the right kind of organizational culture, the right kinds of supports and training. We need to have a community, a context, a setting that is willing and enabling of all that stuff. And if we do all of those things, we'll have improved outcomes. And we're talking about suicide, we're talking about decreased death by suicide, decreased attempts, decreased suffering for many people. There is a whole literature on implementation science. This is a book that's very good. We've worked closely with Dean Fixon and his team in developing all our tools around implementation science. Our website at the center provides direct links to ways to learn how to do this, learning modules just around implementation science. There will be more of these e-seminars on evaluation, implementation, youth and family engagement. This is a taste at this point in time. But when you're doing implementation, you want to be intentional, explicit, and systematic. It's not a light switch and everything gets better. You have to commit to it on the long run, as an individual, as an agency, and as a whole community. I think this is pretty obvious. No one's going to be able to do this by themselves. It takes a lot of partnership. It means that you have to have engagement inside your organization, outside your organization. You have to work on those relationships. And you need it at every different stage. You need about it to identify what the problem really is. You need to figure out what's going to fit in terms of evidence for your community, how you're going to evaluate it, and how you're going to keep it going over time. So this might sound corny, but I really believe it. Working together, we will contribute to the creation of safe, caring, and supportive environments that maximize well-being and strengthen young people, families, schools, and communities. And I think we can add, save lives. So this is our Twitter feed. This is the website for Together to Live, where all the resources we talked about are available. Below that, you see the website for the Center of Excellence with many more tools as well around all the topics we've talked about. And I think we have covered most of the material. Now we're going to open it up for questions, and I know my colleagues have been tracking questions all the way through. So if you can feed me some, I'll do my best to answer them.
For sure. So we've had a few questions come in so far, and I'm going to start with one that's actually just referring to language. So I think that's more a general question that's important when we're talking about these issues. And they're asking what language is most recommended when referring to mental health disorders, so mental illness, psychiatric disorder, and so on, as these words are often used interchangeably in the literature.
So it's a very good question, and I think it's more than just what's the best word. We've actually had families and young people tell us that they had problems with language, and we asked them to help us develop language that made more sense, and they couldn't do it. They couldn't find a common language. Certain communities had different use of words. Some wanted to talk about wellness rather than illness. Some wanted to talk about psychiatric. So it varied tremendously. So I think we have to always be sensitive to language, but language in context. And I would never want to impose a language on a given community or cultural group in any way, shape, or form. Having said that, there is very specific dangers around language when we talk about suicide prevention. And I hope you did not hear me use the term commit suicide in my talk, because I strive to never do that. Why? Because historically the word commit is associated with a crime. Suicide used to be a crime. When we use language like commit, it actually contributes to stigma. It's a death by suicide. That's what's more appropriately. I don't like using the word that there was a successful attempt. I don't know what's successful about someone dying by suicide. There's some research that's been done, especially with young men, that they will find more lethal means because they don't want to have an unsuccessful attempt. They don't want to fail at that too, so they make sure that they're not going to be discovered or not going to be able to turn back. So let's not use language that makes the problem worse, that increases stigma. We can catch ourselves in our day-to-day language. Again, I really like the language of the First Nation partners and colleagues that have really pushed us to talk more about life promotion than suicide prevention. That has personally changed how I view all of this, and where can we view youth engagement as an even more significant piece to wellness promotion. So language is important, but there is no prescriptive way of saying that it works for everybody, unfortunately. Other questions?
So we have a couple of questions that are looking for your thoughts and opinions on approaches and programs. So the first one is from Jacqueline. She was asking, what do you think about the CASE approach, C-A-S-E?
Jacqueline probably knows more about the CASE approach than I do. I mean, there are so many acronyms out there, and I can't say that I know the specific literature on the CASE approach. I've used the CPR approach, which is often discussed in suicide prevention training with ASSIST, and most of these approaches look at similar kinds of things. They're looking at past behavior, current behavior, risk factors, protective factors, differentiating between someone that just has thoughts about death but no real intent, to those who have more intent, which increases the risk, and those that have a concrete plan increases the risk even more. But I also tend to ask people if they've had this, what has kept them from doing something up to this point, and try to mobilize their own personal resources whenever possible to increase protective factors and decrease risk factors. But I wish I could give you an informed answer in terms of what the research says about the CASE approach, but I can't.
Our next question is asking about the good behavior game, which was referenced earlier. And Christine is asking, are there unintended consequences of the good behavior game?
So the literature on the good behavior game, it's a skills training approach, but they also track outcomes in terms of suicidal thoughts and behaviors. When you have an approach, it never works for everybody. And I'm going to give a different example, not the good behavior game, but I know when you do some gatekeeper training around with peers, especially in First Nations communities, there seems to be a triggering effect. And that what might work really well in the literature may not work for certain subgroups. So I think any time that you're applying something, even when the evidence base is there, I would look for outliers. I would look where you have people that are more resistant, where it might be triggering, where you're working on good behavior, and perhaps it provokes some people to exacerbate some of their negative behavior. So each case is different, which means that as you're applying it, if something's not working for an individual, even if it's working for the majority, try to figure out what's going on for the individual, why you might have some negative outcomes. If negative outcomes are too frequent or too severe, then question whether you should apply it generally or not. So the good behavior game, if there are some unintended negative outcomes, they have been small in number compared to the benefits. That's that balancing of benefits versus costs. But if you have different outcomes in your environment, I would suggest that you actually report them to the authors and the purveyors of the good behavior game, so they would have that information for any modifications they need to do for a context that might be creating some more negative side effects. And I'm sure that they would be open to hearing that, because anyone that has a program always wants to improve the program as much as possible, definitely doesn't want to do any harm.
So Carrie was asking if you know of sample protocols that are available for an organization to implement with regards to youth suicide, particularly for the case managers who may have had a client who died by suicide.
I know that there is an organization in Ontario called OnCapes, which is looking at inpatient wards where the risk of suicide is greater, and they have a lot of young people with risk, and there are a number of protocols that they have in place for those that are managing those cases on an inpatient basis. I'm not sure what their website is, but I'm sure that if you Googled OnCapes, ONCAIPS.
Put it in the chat box.
Okay, so we'll put it in the chat box for you. We did some work with them where we reviewed some of the protocols in place for that. We also, I think, have done, we at the center have something called Evidence Insight, where if you have a question about things like protocols or evidence, you can ask us. We will review the literature for you and tell you the best available evidence on something. So if you're asking a question today that we can't answer, if you go to Excellence for Child and Youth Mental Health website, you will see in our hub, there's a place called Evidence Insight. You can actually go there and we will help you access evidence on very specific things. But we did that for OnCapes, and I'm sure that they'd be happy to share that with you. But there's, in terms of school policies, there's quite a large literature. The University of South Florida in particular has done significant work on policies and procedures in a school context. Some of those are referenced on Together to Live website. A lot of those are referenced in the document from School Mental Health Assist that I referenced before. And it's a massive amount of tools that you can use. Some of those tools can actually be used in context other than school. So that's where I would direct you first and foremost.
So a couple more questions. One is around providing a concrete example of a screening tool.
Okay. A concrete example. So there are so many screening tools out there. Some of them are long questionnaires like suicide potential rating scales, like 30 or some items. Some are very short. Basically, the question that the YouthNet program has used for years, they ask about past suicidal thoughts, present suicidal thoughts, and any past suicidal risk and behavior, any attempts. And that leads to a follow-up, which is using that CPR approach that I mentioned before. The challenge is, how do you use a tool that is short enough that you can use, that doesn't create a burden, and don't use a tool unless you can follow up with it. You should never use a tool unless, a tool does not tell you whether someone's going to attempt to kill themselves or not. It'll give you a sense about whether more questions are required. The tool that is the best tool, quite honestly, is to ask the question in a direct way. I ask every young person that I see clinically about numerous things: risk-taking behaviors, drugs and alcohol, sexual behavior, strengths and weaknesses, their social network, self-harm, including what they do when things get very, very tough. How do they cope? Have they ever had thoughts of killing themselves? Ever purposely tried to kill themselves? When was the last time they felt that way? That gives me a sense of what the risk might be, and then I also look at who have they told, who's giving them help for this right now, and then I provide the help in terms of intervention for that, or I bridge them to an appropriate service. On our website, Together to Live, you will find a section that will have screening tools on it, identification tools, I believe, and you'll see there are various links. The center also has a measures database that has tools on just about every topic you can imagine. But again, you have to use them in context. Not every tool is applicable in every context. Some tools are only available in English, for example. Some would never be able to be applied because they just take too long to do. So I suggest you use your judgment. On our measures database, we also talk about how much tools cost. And some are free. They're in the public domain. Some are not, which is why when it comes to suicide, I believe in short tools. They're in the public domain. Most of them are based on best practice and looking at the attributes that I just talked to you about, looking at thoughts, ideation, intent, behavior, and any actual plans.
Okay, so we have another question, Ian.
Yeah.
And Lisa is asking if you can speak to how best to support a school community when the death is not disclosed as a suicide. but the youth are talking about it. And so there are a couple of folks echoing that that's a real challenge, as some students do disclose that to others, but it's not officially disclosed as a suicide.
So this is a very challenging thing because families have preferences around these things. Suicide, there's a lot of suicide, stigma associated with suicide in certain cultural groups and certain religious groups. It's very difficult to admit that that might be what's occurred. Certain parents don't want to believe that their child would have had those thoughts or those behaviors, and they may not permit a public disclosure of that. With social media now, there's a lot of information that travels very, very quickly. And unfortunately also a lot of misinformation. So what you're trying to do first and foremost is to, whenever possible, find out what is the accurate information. What are you able to disclose? How do you engage with the family? And again, you'll find this information particularly on the School Mental Health Assist guide I talked about in the University of South Florida. There are samples about how you can send letters out within a school about information, and even how you negotiate with the family how that information needs to be framed. I think we have to be aware and not naive to the fact that even if someone doesn't give permission, information flows. And sometimes it might be going back to the family again and saying, we don't want misinformation to be going out about your son or daughter's circumstance. We don't want young people to be struggling with how to interpret this. Can we find a way that makes sense for your family, and makes sense for our community, so this can be a teachable moment as opposed to others potentially suffering? I think by having those kinds of conversations, you can reach a common ground where you can disclose more publicly things within a school context that can be protective. But if you're aware of misinformation in particular, that's where the lack of information is causing a problem. And that's where you use that misinformation to say, let's get this right for everybody's sake. In most instances, you'll find that you can find some middle ground. When you can't, then you still have to deal with the fact that there was a loss. As if there was any other kind of loss. Sometimes it's accidental, sometimes it's not. It's always tragic, and you still have to provide supports around the loss, whether it's labeled as suicide or not. You guys are asking good questions. You're making me think way too much. My head hurts. Any other questions?
So those were the questions that we were tracking throughout the session. We did put in a prompt for final question. I see someone is typing, so we can see if there is one more question coming through. I know Sophia, I think, has some wrap-up comments for folks.
Maybe we'll see.
We'll just see what the other question is. And so before we get to the last question while they're typing, this was an hour presentation on evidence in suicide prevention. It would take a year to go through every single program that exists out there and give you a review of what level of evidence exists. And I would not pretend to know every program and every protocol that's ever been done. That's why things like the decision support tool that I mentioned would guide you in how you look at the literature. There are places where the information is held. There are clearinghouses of information around these issues. In the United States, the SAMHSA has a clearinghouse of information. We have links to that on our website, and you can find that pretty easily. And they'll show you what tools are out there, what evidence is there, and the level of support that the evidence has for different things. And so if this is an important topic to you, I would ask you to not stop asking questions. If you are going to use evidence, use it with a grain of salt. Don't assume it's going to answer all your problems or will fix everything for everyone. Make sure that you evaluate how you use it and what happens when you use it, and what do you need to do to keep using it if it's actually working, and then share the information with others. And if you're not sure, you should ask. You can ask places like the Center of Excellence. You can ask partners in education like School Mental Health Assist, and if we don't know the answer, we will point you in the right direction to someone that will know the answer. So did the question come through?
No, I think
people they've had enough.
People are just thanking you for the wonderful knowledge and information that you were able to share with them today. And certainly, we loved having you present on this. As some of you may know, this is Ian's last month working here at the center, so it's been an honor to have him present on this forum before he goes on his new adventure. So thank you, Ian, and thank you all for joining in this first e-forum. This is our very first one ever we've done through Adobe Connect, so we're happy that you're all able to join us. And as you know, this is part of a series, so there's 4 other forums that will be coming your way in the new year. So the next forum will be on youth engagement and youth suicide prevention. So that has been sent out. The invitation for that has been sent out already, and the registration link is active on the event webpage on togethertolive.ca, which we would have put through the chat box for you today. That one's on January 13th from 11 a.m. to 12:30 p.m. And I think Ian touched on some of the other topics that we're going to be looking at in other e-forums, so evaluation is another one to look out for, as well as sustainability planning. So stay tuned for that. And I think that's it.
Evaluation of this.
Oh, yes. And then the evaluation for this e-forum, we really want to hear your input. We're going to use that information to improve our future e-forums. So please take the time to fill that out. And we will follow up with an email with the recording as well as the presentation slides once we have them on the event webpage. So stay tuned for that in your inbox. And I think that's it. So enjoy the rest of your day, and hopefully we'll see you at a future forum. Thank you.